And we move to the satellite symposium of Boehringer now.
Probably. So let's continue with the symposium of Boehringer. So I would like to ask the technical guys to prepare the slides of the Boehringer symposium. In fact, dealing with a very important question, the question of heart failure. Момчета, ще се справите ли или да продължаваме с slide case? Okay, excellent. So the topic of my presentation, together with Dr. Garvansky, we are going to speak about this very important and hot topic. During the last several years, it's definitely a hot topic because there are several new players on the terrain. And after a huge gap in the medical treatment, we have for several years, several new agents. So the early initiation of agents like empagliflozin, that is one of the SGLT2 inhibitors that giving hope for better treatment and better prognosis, is the topic of my presentation. So the heart failure is, in fact, is one of the biggest killer nowadays. You know very well that the majority of heart diseases are, in fact, in the late phase. They are expressing in heart failure. So many factors are important, but one of the most important reason to speak about is because of the huge burden of hospitalization, mortality, and invalidation related to heart failure. And the other one is very important, that 80% of the diagnosis of heart failure is late. So it's underdiagnosed and undertreated condition. Of course, not everywhere. For example, Bulgaria is one of the countries that is not dealing very well with heart failure management. We know very well, I mentioned already, that there are several conditions, heart and metabolic and cardio-renal metabolic conditions that can finally park into the heart failure. In the nowadays aging population, sedentary population, obese population, all these three reasons are very important to understand why the heart failure is so much prevalent in our society. So the cardio-kidney metabolic syndrome is probably one of the biggest trigger, but in fact it's also one of the biggest victim. So all these conditions are worsening not only worsening the prognosis, but also worsening the quality of life. Quality of life is a very important parameter during the last 5 years as even as an endpoint in many trials. And the heart failure is one of the biggest reason for quality of life being destroyed. And this is also one of the reasons to take really a big attention to the efficient therapy. And in fact, several trials like EMPA-REC, EMPA-ROR, and EMPA-KIDNEY have shown the early utilization of SGLT2 Jardiance empagliflozin utilization is very important in order to improve the prognosis. For example, the EMPA-REC outcome have shown that Jardiance over the standard guidelines based treatment is reducing MACE, is reducing the hospitalization incidence, and reducing the kidney problems. And probably, of course, the most important outcome in the medicine is mortality. In fact, in the EMPA-REC outcome, it was shown that Jardiance compared to placebo over the standard therapy is reducing by 38 in dramatic 38% reduction of the cardiovascular mortality and 32% reduction of general mortality. And the other very important and really breakthrough is that the SGLT2 inhibitors have shown finally that we have hope, not only hope, but also good and reliable treatment in patients with not only reduced ejection fraction, but also with moderately reduced, and even without reduced ejection fraction, we have reliable treatment. And this is very important to show that there is similarity of reduction, of rate of reduction, both for reduced and preserved ejection fraction, reduction of the mortality in these settings. And this is the same graphic showing that this reduction is coming very early. So even as early as 12 days after the start of the therapy, we have really reduction of this parameter. And also very important, the burden of rehospitalization is really a very important burden to be reduced for the cardiovascular care systems, and there is also 30% reduction of rehospitalization. The normal ejection fraction we had for many years. We didn't have any precise therapy more than giving diuretics. We didn't have other methods of treatment, but nowadays we have several, and in fact SGLT2 is one of them. It's very important that the guidelines and the clinical situations not only are advocating now not to titrate the therapies, the so-called Fantastic Four. If we add the diuretics, it's the Fantastic Five. So the guidelines and the new algorithms advocating not to titrate too much one medication and after that to start another one, but more rather than to start with several medications or relatively low dose in order to have the pleiotropic and synergistic effect of several of these medications is very important. So as early as better. So this is crucial. And of course, it's not also the combination. It's not all the combinations are the same. In this slide, it's very well shown that in fact, among all the combinations that are including the SGLT2 inhibitors, in fact, the rate reduction, the hazard ratio decrease is the biggest in the group of Jardian's empagliflozin inclusion. And this is a very important that even since the starting of the treatment in the hospital, so during the hospital, it's definitely not only allowed, it's indicated to start the medication inside the hospital and to continue giving the medication even in recurrent rehospitalization. Unfortunately, the inertia, the medical inertia is typical not only for Bulgarian physicians, but also for the physicians all over the world. And this is one of the reasons to start not early, to start late in the line of the heart failure, and not to allow the patient to benefit with this initial very early improvement and benefit that they have. And including the hospitalization, in fact, in the guideline, the recurrent hospitalization is considered one of the good reasons to start the new medication under the control of the treatment team. And because of that, especially the SGLT2 is very important that they are reducing even the collateral effects of the other related to heart failure medications. And because of that, the SGLT2 inhibitors are one of the most early allowed to be included because they are not related to hypotension, for example, like like the ARNI. We know very well that medication like ARNI that are very good, no doubt, but unfortunately patients with hypotension, it's not possible to be put on ARNI medication. With the SGLT2 medication, this problem doesn't exist, and because of that, we can move the start of the SGLT2 early in the approach of treating the heart failure. The metabolic kidney heart failure syndrome is very important, and I have shown previously, but also there is a special trial regarding the kidney function preservation, and this is very much related not only to patients with reduced, but also to patients with preserved ejection fraction. And we know that in all the specialties, the kidney function and the kidney failure is one of the worst factor for reducing the survival. And it's in fact it's very important to mention that in all the continuum of indications in heart failure, the SGLT2 is definitely not only allowed, but it's indicated to be included. And we know very well that this is one of the medications that started as an anti-diabetic, and during the investigation, the medical societies, we have realized that it's not a simple anti-diabetic, but it's a special multifunctional and pleiotropic effect with the SGLT2 medication. It's very good. I mentioned several times, but in fact, the combination of cardiovascular mortality and hospitalization reduction of 21% is definitely very important, and the most important is to mention that this effect is coming as early as day 18 and after that, both for mortality and for reduction of hospitalization. And the beauty of this trial, EMPA-Kidney, that is treating, in fact, the target is to protection of the kidney function on patients that are put on empagliflozin. It resulted in EMPA-Kidney that the Jardiance is reducing the progression of the kidney dysfunction and also the risk of cardiovascular mortality in patients with chronic kidney disease. So there is a very important protective effect of this medication. And these are, in fact, the reason to apply the Jardiance early in the diagnosis of heart failure, and to combine with all the rest of the medications that even more, it's important to know that there is not only the tablet of 10 milligrams, one tablet, but also there are several combining medications, mainly with anti-diabetics like Synjardy, with combination, and also Glixambi, and it's definitely important to have in mind that we have in our armamentarium the combination treatment of this medication, and it in favor of our patients. And thank you very much for your attention. I'm giving now the floor to Dr. Garvansky. He will speak. Okay.
Okay. I will continue with empagliflozin and probably a little bit more about the SGLT2 inhibitors in general. And I will talk about one, I think, underestimated effect of that class of medication, which is the antiarrhythmic effect, or the effect on arrhythmic events. First of all, I'd like to say that empagliflozin or any other SGLT inhibitor is not an antiarrhythmic drug, so don't treat it like that. They are not indicated for that. I will just present the results from few trials, which probably lead us to a conclusion that those type of medication probably affect the occurrence of arrhythmic events of all the spectrum. And why is that important? It is important because the arrhythmias and heart failure are a very common comorbidity. And the reported prevalence of atrial fibrillation in heart failure studies ranges from 13 to 27%, which is 1/3 of all the patients have that two comorbidities combined. And sudden death is still considered an arrhythmic event in most of the cases, is the most common mode of death, not only in patients with HFrEF in heart failure with reduced ejection fraction, but in those with preserved ejection fraction. And why those relatively healthy hearts may have a sudden cardiac death? Of course, it is less common than in those with very ill hearts, but it can be due to reduced conduction velocity due to ventricular hypertrophy, delayed repolarization caused by downregulation of potassium, calcium leakage, and reentry circuits provided by the ventricular fibrosis. Okay, the mode of death in HFrEF and HFrEF patients is slightly different, but still, in 25% of HFpEF patients, we still have sudden cardiac death. And although lower than HFrEF, it is a considerable number. And if we can influence that, I think it is of huge importance of our long-term success in treating those patients. We proved to be rather successful in recent years in terms of sudden cardiac death in patients. Those are the combined data of the trials from the last 20 to 30 years about heart failure patients. And you can see that the sudden death decreases over time. So we are doing a good job. You can see the first trials, the rails, which is for spironolactone, through SCUT-HEFT to Corona, Emphasis, and Paradigm. You can see that even the control group experiences quite lower events of sudden cardiac death. And this is again proven in the all-cause death in those patients. So adding on top of that is a challenge. And everyone who treats heart failure can tell you that nowadays we have our patients with heart failure live longer and better than the heart failure patients of the past. And I mean, not so distant past, even 15 years ago, our patients were not having that good results in terms of clinical outcomes. I noticed in my practice, because I am an arrhythmia doctor, that when we treat patients with SGLT2 inhibitors, their devices, their pacemakers, record less arrhythmic events. And this got into my attention. Why is that? So I did research a few years ago when I started doing that, and I have even presented a few times this as a case reports or something like that. But still, why empagliflozin can act as an antiarrhythmic drug? In this very complicated scientific document, it is shown in mice models and in isolated ventricular cardiomyocytes in human that empagliflozin reduces the KM-MK2 activity both in failing and non-failing mice hearts, and it can result in a significant reduction in a sarcoplasmic reticulum calcium leak. And if you remember that the calcium leak of the sarcoplasmic reticulum is a mode of arrhythmiogenesis. It's part of the after depolarization. So this may be a possible effect. That scientific data gathered and led to a creation of few meta-analyses. This is probably the biggest one. It includes 52,000 patients from 22 trials, and it is specifically made to look of arrhythmia events in those patients with SGLT2 inhibitors. And what were the results? They may seem not that impressive, but still, if you consider atrial fibrillation, you can see down it is an 18% statistically significant relative risk reduction, which favors SGLT2 inhibition, which is translated to atrial fibrillation and atrial flutter reduction in that same group. Still, take this data with a pinch of salt, because the trials on their own and different agents on their own, they do not reach statistical significance. They reach statistical significance only when done in this meta-analysis. So, okay, there is probably a hint that probably there is some antiarrhythmic effect, even in that huge group, but still, the results may vary quite a lot. It's the same with ventricular tachycardia, which is a probable life-threatening event. You see that still it is a 27% risk reduction with a statistical significance with confidence interval of 0.53 to 0.99. So just slightly statistically significant, but still, it's 52,000 patients, so okay. Regarding atrial flutter and cardiac arrest, there is no statistical significance. Again, we have numerical favor of SGLT2 inhibition in both groups, but still not statistically significant. Okay, so after that, a proposed trial was done. It is called the EMPA-ICD. It was performed in 150 diabetic patients with an ICD or CRTD implanted for a different indication. And there were randomized 75 of them to receive empagliflozin and 75 to receive placebo. And what was followed, the arrhythmic events in those groups, because every pacemaker is a type of Holter on its own. It can record different types of events. It can record ventricular or atrial arrhythmia, so we can measure that. And it is always on, so patients, we have monitoring of the patient's rhythm all over when they're carrying their pacemaker, and this is all the time. Okay, here are the indications for the ICD. It was almost ventricular fibrillation, the primary prevention, which is the most important group, I think, which is less risky, only 16% in both groups. Other were higher risk patients. And what we see is that in the empagliflozin group, after 24 weeks of treatment, we see a reduction of the recorded arrhythmic events by the ICD with a rate of minus 1.69 events. And in the placebo group, we see an increase of the arrhythmic events of 1.79 arrhythmic events. What about the other very common arrhythmia? Not only the ventricular arrhythmias, of course, are a thing that concerns us. As I said, 1/3 of the patients have atrial fibrillation as well. Here we have data from, again, a small trial which included only 23 patients with an ICD, again, to use its recording purposes, and which were prospectively followed before and after initiation of empagliflozin. 1 year they were followed up before we initiate empagliflozin, and 1 year after. And what we see is that we see a decrease in the atrial fibrillation episodes and atrial fibrillation burden here in the right corner. You can see that after empagliflozin, the patients have a mean of 303 arrhythmia-free days and only 2.3 episodes of arrhythmia. And regarding that data, a huge meta-analysis with more than 38,000 patients with diabetes 2 showed us again that regarding empagliflozin in the lower part and dapagliflozin both have show a reduction of atrial fibrillation and atrial flutter events in those patients. As a conclusion, I think that SGLT2 inhibitors significantly reduce the arrhythmic events in patients with diabetes and heart failure that we have seen in those meta-analyses. And the exact mechanism, of course, is not completely understood, but I think that treating heart failure well is part of the answer. The blood pressure control, the better glycemic control, and probably that molecular effect which I mentioned in the beginning, those are probably the possible mechanisms in this. So thank you.
Thank you very much for your wonderful presentation. Any questions?